Everyone, thanks a lot for joining. Great to have you. Our IFC series of webinars. Today we will be talking about radiology, how to make radiology safe and effective, and what is the role of accreditation in radiology. And I'm happy to introduce the first speaker, Dr. Hend Sherbini, CEO of Integrated Diagnostic Holding, Egypt. Dr. Hend, over to you, please.
Good afternoon, ladies and gentlemen. Thank you. I want to thank IFC for inviting me to this webinar today. So my name is Dr. Hend Sherbini. I'm a CEO of IDH, or Integrated Diagnostics Holding. And let me give you a brief about IDH. So Integrated Diagnostics Holding is a leading, fully integrated provider of high-quality medical diagnostic services with a footprint spanning Egypt, Jordan, Nigeria, and Sudan. Our pathology service includes immunology, hematology, molecular biology, endocrinology, clinical chemistry, histopathology, genetics, cytogenetics, microbiology, and we also provide radiology service. We've been in the market for more than 40 years, and we are accredited by the College of American Pathologists, the ACR, the American College of Radiology, the GCI, and ISO 15189. We have several brands. In Egypt, we have Al-Mukhtabar, Borg Lab, Borg Scan. In Jordan, we have Biolab. And in Sudan, we have Ultralab and Al-Mukhtabar. And in Nigeria, we have Ecolab. IDH is actually managing or serving patients through 540 branches. And we have done around 33 million tests last year, and we served around 10 million patients. Our quality statement is that IDH and its employees commit themselves to the high standards of quality by striving to meet and exceed their customers' expectations in the service they provide through the process of continuous quality improvement. To maintain the position of a leader in the laboratory medicine, IDH invests both time and financial resources, choosing high-quality suppliers and materials, having state-of-the-art physical designs, and releasing high-quality results by high-quality employees, which all contribute to achieving the standards of excellence. So when we thought about accreditation, we chose the College of American Pathologists as it is the gold standard of accreditation in laboratory medicine. Why the College of American Pathologists, or CAP? Because the CAP accreditation program improves patient safety by advancing the quality of pathology and laboratory services through education and standard setting, and ensuring laboratories meet or exceed regulatory requirements. The CAP has also a comprehensive scope covering all units of the laboratory medicine. Although lab tests represent only 2% of healthcare spending, it influences 70% of medical decisions. So laboratory testing is an essential component of improved healthcare for patients, especially in resource-limited settings. Accurate and rapid diagnostic tests are required to diagnose illness, identify causative factors, monitor the effectiveness of treatment, and perform surveillance for key diseases. Reliable and actionable test results are often a prerequisite to the delivery of high-quality patient care. And as you've all noticed, the importance of laboratory testing during the COVID pandemic. Our accreditation journey with the CAP started in 2007. So Al-Mukhtabar participated with CAP proficiency testing in 2007. We received our first accreditation in 2010. We were the first and only CAP accredited lab in Egypt. In 2012, we renewed our CAP accreditation. 2015 was the initial operation of our mega lab, Egypt's largest automated lab. In 2017, the mega lab received its CAP accreditation, and we renewed it every 2 years since then. In Egypt, we are the only CAP accredited lab. In Jordan, Biolab is one of two CAP accredited labs. So we're very proud that we've been CAP accredited for more than a decade now. Late 2018, we started diversifying our service offering by providing radiology service under the name of Borg Scan. Borg Scan is a premium service provider of radiology service, providing patients with a one-stop shop where they can get laboratory and radiology services. Radiology services include MRI, CT scans, ultrasound, X-ray, mammography, PET-CT, all with the latest technology and highly trained staff. We now operate 6 centers. We have served 170,000 patients, and we've done 220,000 scans. We also looked for accreditation, and we chose the American College of Radiology, ACR, as it is also the gold standard for accreditation in radiology. Borg Scan applied for the ACR accreditation of 3 modalities: nuclear medicine, ultrasound, and CT. It earned the ACR accreditation for its nuclear medicine and ultrasonography on August this year for a 3-year duration. CT accreditation is still pending, waiting the ACR approval. Through a complete review of the facility of Borg Scan equipment, medical personnel, and quality assurance processes, ACR accreditation helps guarantee that patients receive the highest level of image quality and safety. Over the last 2 years, IFC healthcare quality expert worked closely with the Borg Scan team to evaluate the baseline level of implementation of quality standards, as well as provided guidance on required improvement in its infrastructure, policies, and processes to fully comply with ACR standards and requirements. Borg Scan is the first radiology center in Africa and one of the only radiology facilities in the Middle East to boast this prestigious certification. Thank you very much.
Thank you so much, Dr. Hend. It was very important to hear about the journey of IDH, about the development of Borg Scan and the process of its accreditation, because we all understand that accreditation is an important instrument in the journey of improving quality and patient safety, and also safety of staff, especially in such a potentially dangerous department as radiology. And now let me introduce our other speakers, the team that was working on getting the accreditation of American College of Radiology. On IFC side, we have today Joseph Williamson and Aisha Lewis. And on the side of Borg Scan, we have Dr. Ahmed Wafaie, Professor of Radiology, and he is the head of Borg Scan, and Dr. Yasser Al-Said, Professor of Nuclear Medicine, also from Borg Scan. So if the floor is yours now.
Okay, good afternoon or good morning or good evening, wherever we're hailing from. And I see that we have a lot of participants from pretty much everywhere. And this is very exciting for me. Aisha and I always talk about this as being the cornerstone of our life breath. Our life's work is diagnostic imaging. And so I kind of like to change the topic from radiology to diagnostic imaging, because people think about radiology, they think, oh, you know, there's radiation, we're going to be exposed, but ultrasound is also part of diagnostic imaging, so is MRI, which neither one use radiation, but it's still a safety issue. So as we look into this whole component of imaging or radiology accreditation, a couple of questions come to mind. First of all, why are we even talking about accreditation? What's the point of accreditation? You know, a lot of people ask me, and Aisha's had the same question, well, why should we become accredited? We're already doing the right thing. Well, let me ask you a question. If you were about to take off on a plane, you find that plane was not a member of the FAC, would you still fly that plane, right? Because they're still doing the right thing. What that does what the FAC and other accreditation body does, whether it be airplane, stockbroking, communication, everything has accreditation bodies. And it does 5 things, actually. 1, it improves the outcome of whatever it is that you're in. So if we're talking about accreditation of hospitals, accreditation, it has been proven that it improves the outcome of patient medicine, right? Number 2, accreditation identifies strengths and gaps in your program, whether it be hospital, radiation, pathology. Once you go to accreditation body and they start to look at your program, they will identify these are the gaps that need to be filled and these are the strengths you have. Number 3, accreditation promotes communication. Why is communication important in your staff? Because if your CT department is not talking to your MRI department, if your MRI department is writing up reports that are different than your CT department, there's a problem. Because oftentimes you're referring to the same doctor. They're looking at 2 different reports with the same patient. It doesn't make any sense. So there has to be communication. And lastly, this is the most important thing. And Dr. Han brushed on this, and you're going to hear it over and over again. Accreditation fosters culture of quality and safety. I'm going to say it again. If you don't remember anything else that we said today, accreditation fosters a culture of quality and safety. Radiation is one of the most dangerous practices in medicine. Okay, we look at a nuclear lab. The nuclear lab, man, I can use the nuclear lab in a movie about how to blow up the country. Okay, because there's so much dangerous material in the radiation nuclear lab. That hot lab with the pharmaceuticals that we have there is very dangerous. How do we control that? How do we control that? We have to come up with some quality standards, right? Quality program for radiology is very simple, right? But not a lot of people have it. When I go from radiology department to radiology department, both in and out of the United States, you'd be simply surprised how many radiation departments, radiology departments do not have a quality program. What is a quality program? I'll answer that question. A quality program is simple. It's a series of protocols that you've developed and implemented within your medical imaging center that focuses on, what is it? Continuous evaluation and improvement of patient care and everything related to patient care. It's very simple. It's very simple. It's like a roadmap. And those of you who have ever traveled and got lost know if you don't have a roadmap and you don't know where you're going to get lost, right? So this is a roadmap for you to go on your quality journey in radiology. And we're going to go through how accreditation helps you do that, okay? Patient care is affected by clinical standards. Accreditation looks at all these clinical standards. I'm going to go through the first one, let Aisha go through the second and third one. Standardization of patient care is very important. And I brushed on this before. If we have a radiology department that has 3 or 4 modalities, and each of those modalities is behaving differently with the same patient, that is not standardization of patient care. When I look at the overall production of reports and patient results, they should be standard. If I'm a doctor, I'm a radiologist reading one type of exam, the doctor sitting next to me should be reading that exam the same way. The report should look the same. I'm not saying the results are the same. I'm saying that the report should look the same, right? If my department is doing quality control in a certain way, and my department is ultrasound, then the department next to me, which may be CAT scan, should also be doing quality control. We cannot have a department operating in different ways all around because you can get mayhem, you're going to get confusion, and you can get miscommunication. So when we talk about standardization of care when it comes to accreditation, they want to make sure that your department is operating at a standard rate, your reports look the same, your patient care look the same. When I talk about your radiation outputs, they're the same. Everything is standardized across the board, okay? Now, Aisha, tell us about the protocols. What is the standardization of protocols?
Thank you, Joe. Hi, everyone. Thank you for being here. It means a lot for us that you really care and you want to practice the best. That, like Joe said, there are 3 words, key words we are going to continue to use. You guys are going to be tired of: standardization, quality, and safety. That is the 3 important keywords in radiology. Protocols. So what's protocol? Why is that important? It is so important the way you practice radiology. Protocol could means what are the protocols set in CT and MRI, ultrasound, and other modalities. And also between team member to team member, is the protocol the same? Is everyone following the same protocol? There are important images that you have to take in certain modality in a certain protocol, but sometimes we miss it. We don't know. And the great thing is ACR provides the important images that you have to take in each exam, basically. So you have to have a structured protocol in each modality, and you have to have a format where one person is out, the other person can follow the same format. So the radiology gets that quality of work, and they're able to diagnose everything appropriately and timely. Because if you were to miss an image on a CT and you didn't just go down a little further down to the pelvic, which you should have, then that's a big difference. Same with ultrasound. If you were to not take the certain angle of gallbladder, you know what? You can't tell if the stone is mobile or if it's stuck around the neck. So it's really important to have those key images, and then it's followed by every team member. And that's the set of protocols, set of standard you want to set in your practice. And the report quality, Joe touched on it a little bit. What's important about report quality, it comes in, we have it structured in this image, as you can tell, standardized care, protocol, and the report quality. All of those goes in the same format and the same structure as we set up. So if you don't take the right images or follow the right protocol, then the report comes out as they don't mention it, because you don't sometimes have all the radiologists coming in to the actual scanner scanning it. So whatever you produce from your protocol, you submit, and the quality of the report is what it states. That's your final component that you give to your patient and you give to your referring physicians as well. So how that's structured with, indication, what is the patient's, why are they here? What kind of treatment are they going through? There is a structure of quality work in a report quality. And we went through it with Dr. Ahmed, Dr. Yasser, and they took it so well. And we have a format of report that we shared with them, and they structured it and they developed it. And, it really is important to have the same structure and same quality of report in radiology as well. Joe, back to you.
Absolutely. Thank you, Aisha. And to add to that, I'm going to step on a few toes here. We have to come out of the dark ages. Okay, when it comes to medical images, we have to come out of the dark ages. Gone are the days of having a piece of paper and writing on it, patient has gallstones, sign the doctor's names, and hand it to the patient. We cannot do that anymore. Our equipment has taken leaps and bounds, okay? We have digitized equipment now that when I started practicing, I was still hand dipping X-ray film and developing. And those of you who are young don't remember when we had X-ray film developers and we had to hand dip it and move it to the fixture and move it to the developer. Now we have laser imaging. Now we have digital imaging. Our reports have to keep up to our technology, right? After we finish an exam, that report has to match the exam. And that's what it means, image to report accuracy, the last one. You remember that the doctors that refer to us in imaging are not always going to see the pictures, okay? They send it for a HIDA scan. They're not going to be looking at that gamma camera result. They don't know what it is. That's our job to tell them, here's what the patient presented with, here's what our finding is, and guess what? That finding is equal to what I saw on the image. One of the things that accreditation is going to do, whatever accreditation body you choose, they're going to ask you to say, look at your image, look at your report, does it match? If I say that there are, there's a 20 cm mass, the image better show that there's a 20 cm mass, not a 24, not a 26, but a 20 cm mass. Those two things have to match. And this is where we get into something called peer review. In other words, we're setting up a program in that our images, every so often, whether it be 6 months, 12 months, 18 months, are reviewed by another set of eyes to let us know that we're on the right track. If I say that the common bile duct measures 12 millimeters and my partner sitting next to me reads that same common bile duct and he's getting 22 millimeters, there's a problem. Okay, there's a problem. We have to go back and find out where the problem is, because guess what? They're real live patients depending on that number, real life patients, right? So that image to report accuracy when it comes to ACR or it comes to any other accreditation body becomes detrimentally important. Now, Aisha said that we're going to be mentioning three words over and over again. I'm going to give you the first two, quality and safety. Okay, we have to have quality and safety. This is something we went over with Borg scan. They have quality and safety. In fact, they had quality and safety before we went to them. We just sharpened it a little bit, right? We just focused it a little bit more, right? So what are quality, what do I mean by quality and safety? What am I looking for? What does accreditation bodies look for when it comes to quality and safety? Well, there are things called quality and safety drivers. These are the things that are in our imaging department that actually push us to go to quality and safety. Number one, why do we want quality and safety? Because we want to provide consistent, and Dr. Hahn said it, consistent, high quality patient care. Consistent, high quality patient care. A lot of times, believe it or not, in medicine, guess what we do? We forget about the patient. You say, Joe, how's that possible? We're treating patients. No, we become so focused on here's how the gamma camera is supposed to look. Here's our report supposed to look. Here's this, here's that. And we forget there's a gentleman, there's a lady sitting in front of us waiting with bated breath for that piece of paper that you're going to hand them to take back to their doctor, right? So we have to become now more patient focused. And this is what accreditation is going to make us do. It's going to make us have well-defined, effective, patient-safe, patient-centered, timely, safe, efficient, and equitable patient care. Right? You say, Joe, how are they going to do that? Trust me, when you go through accreditation, as Borg will tell you, they will make you do it. If you're not doing it now, you'll be doing it by the time you finish accreditation. And you'll find out like, oh my goodness, I wasn't doing this, okay? The second thing is accreditation will push us to adhere, to stick to look at organizational standards, right? Mandated standards that are set forth by people bigger than me, by people bigger than IDH, by people bigger than Nooraiysha. So you look at people like the American College of Radiology, the UK College of Standards, they've set forth global standards. And when they look at a clinic like IDH, they say, hey, how are you doing against these standards that we know is global representative, right? So then we have to say we're either in a gap or we're doing very well. And even if we're doing very well, guess what, guys? There's always room for improvement. I've never, ever been to a hospital. Even you look at Johns Hopkins, you look at University of Maryland, you look at the Mayo Clinic, all these huge hospitals that does not have a quality program that is hell-bent on improving their quality, not maintaining it. Nowhere in there do I see maintaining it, improving their quality. Number three, economics. We need to provide the care to these patients in the least expensive manner possible. You say, how does accreditation help us do that? Well, accreditation asks you, for instance, how often do your pieces of equipment get periodically maintained? You say, well, Joe, why is that important to economics? Guess what? You stop maintaining that gamma camera and see what happens. Seriously, I dare you to. Stop maintaining your MRI and give it about 2 or 3 years and see if you still have a functional MRI. And when you have to replace that MRI, you quickly begin to realize that when you're writing out that check, you didn't think about economics. You didn't think about how can I provide this the least expensive way. We're going to go through this a little bit more as we go through. And then the last one is we talked about high quality patient care, but we also need to talk about streamlined patient care. There's a hospital in India that I'm very well familiar with that they have gotten their patient care so streamlined that when that patient walks in the hospital, there's no questions that patient have to ask. They know where to go, they know when to be there, and they know who to report to. It's all given to the patient ahead of time. There are footmarks on the floor that the patient follows. There's apps, all this stuff, because they want that patient care to be as streamlined as possible. Guess what? Your patients, contrary to popular belief, I know you guys would all like to think that your patients love you. They don't want to be in your place. I'm telling you that right now. They do not want to be in your place. Give them a choice at the beginning of the day. Do I want to go to the park? Do I want to go to work? Or do I want to go get a CAT scan? Nobody's going to say, I want to go get a CAT scan. So the thing is, when they get in there, you want them to be able to get in and out as streamlined and efficient as possible. And the College of Radiology, as well as all the other imaging modality accreditations, have templates to assist you in streamlining your patient care. Your follow-up care on your patient. You know, your doctor's going to read, there's a mass that measures X by X by X. What's the follow-up care on it? Okay, that has to be attended to. That's your impression, right? Improved communication. What does that mean? Communication between yourself and your staff, and yourself and the referring physicians. Three-way communication has got to be 100% all the time. Reduce reading room errors, right? We know that the majority of errors in diagnostic medicine happens where? Not in surgery, happens in that reading room, because it gets crowded, distracted. There's so many things going on at the same time. And the less streamlined that care is, the more apt we are to make mistakes. I've done it myself. Okay, increased diagnostic confidence. That means everything we've just talked about is going to give your patients and your referring physicians better confidence in your ability to diagnose whatever it is they send that patient there to diagnose. Okay, so the next thing is, what are the core goals of accreditation? Well, we already talked about number one, and I know you're sick of it already, but we need to integrate a quality safety program into your radiology practice. Borg scan can tell you when Dr. Ahmed starts speaking that they had a quality program. Did it need gaps closed? Yes, it had some gaps. We assisted in closing them. They did the work. We just pointed them in the right direction. Now what they have is a system of quality that I would be proud to go to. I would feel comfortable going and lying on one of those diagnostic tables because I know that they have incorporated that quality system into their radiology program. Number two, we need to engage the stakeholders and staff. Accreditation is going to pay attention to that. They're going to ask you your staff qualifications. They're going to ask you, who are you referring to? They're going to ask you, what type of doctors are you referring to? Number three, and I'll let Aisha go into the number four, but number three says standardized clinical pathways. A lot of times we forget this. It goes hand in hand with the protocols, right? If I have a patient that presents with an ectopic pregnancy, what is my routine to manage that patient? 4 different doctors cannot have 4 different routines in your clinic. It has to be the same clinical pathway, right? Aisha, you want to touch on the continuous learning?
Sure. So the continuous learning, one of the important things in radiology is, you know, I know in US, we have to continue to get CME credits. I'm not sure in other countries, but I think other countries is developing. You have to have certain credits. So having to provide a continuous learning for your staff on quality assurance is so important. And you could do that by different way. ACR practices by competencies. So how comfortable is the staff with, you know, taking care of that one exam? How well do they know? Because there's sometimes you get an exam, you're like, wow, I haven't done this in a long time, right? But they're like looking at it and looking for it. How do I do this? So having that education on that one difficult exam as a yearly competency for staff, and we will help you put that together from what ACR does. They will ask you in their accreditation, how do you practice continuous learning for your staff? So we'll have a standardization approach of exams or competency that we can develop for your staff. You can either do every 6 months, every year, and each modality, each staff will have the continuous education. Establishing a QA and a patient safety system. It's the same thing. Whatever you have for staff, you got to do it for your patient because they're coming in not knowing what they're about to get done. It's so important to have signs and forms that explains to the patient what they're about to do. I like to say, I'm a very caring person. I like to sit down with my patient, explain to them what I'm about to do, how safe this is, and what they have to do. I think that is so important. That's what we need to practice in medicine because they are nervous. They're coming in either, do I have a cancer? Do I have something going on? Are you going to find a mass? how do you establish a patient safety system where you communicate to them before they even ask you? They feel comfortable, they feel touched and be there with you because they feel comfortable in the system that you develop. ACR really provides a clear definition on how to set those standards and how to develop those for your own practice. Joe, you want to touch on the audit reporting?
Yeah, one little thing about the quality safety patient system as it goes to Aalborg scan. This is one of the things that I noticed that even before we got there, they had in place, because I could walk up to that front desk, pull out a pamphlet and say, okay, I'm going to get a CT. It would explain to me what I'm going to get, you know, in layman's terms. And one of the things that we know about patients is patients are nervous when they come to your place. So can you imagine a patient walking into your regular doctor's office, the doctor has a stethoscope, they're nervous now. But now you walk into a CAT scan tower. You have this huge piece of equipment, lights are flashing everywhere. You've got an injector that looks like a robot with a needle at the end of it coming at you. You have no idea what's going on. But in IDH, what I noticed is the patients were at least a little informed to know that, hey, this is not going to hurt. This is what's going to happen. And the doctors also talk to the patients before they put them on the table. Not after, not during, but before. You and I both know that if you are not hypertensive when you come to a hospital, you'll be hypertensive when you leave, right? Because there's so much going on. Even as an experienced medical person, every time I go to my doctor's office, my blood pressure goes up. Why? Because it's nerve-wracking. If you can put together these patient information and safety systems before, then it does your patients so much better. Now, the auditing reporting, we touched on that before. The report system, I'm going to say it over and over again, the report system in a radiology department is the end all be all of what you do, right? It's the end result to what you've just done. If Dr. Yasser has done a HIDA scan, his report tells me exactly what he's found in that scan, and it's signed off by a doctor and given to the patient. If those reports are not audited periodically, little things can go wrong. I can tell you stories of decimal points that have been moved on reports. So instead of being millimeters, they turn into centimeters. And what happens? The doctor that gets it reads it and says, oh, this is a centimeter. It must be right because Dr. Ahmed said it, and we like Dr. Ahmed, we trust him. Guess what? They take that patient to surgery based on what Dr. Ahmed said, because there is no auditing of reporting systems. You see the danger here, right? So nobody's perfect. Even the best radiologist, the best doctor, the best technologist needs to have their work audited. The ACR and other accreditation bodies will make sure, they'll ask you, show me your auditing forms. And if you don't have one, they'll provide you one and say, show me how you implement it. Okay, so accreditation is a process, right? And with any processes, you have challenges. You have challenges. You know, I know you guys probably all expected me to say the accreditation is a very easy process. You're going to go through it in 2 months. You're going to blink your eyes and you're going to get that piece of stamp on your wall. It doesn't work that way. It doesn't work that way. My dad used to always tell me anything that's worth it is going to be problems. Okay, so the challenges in accreditation process, we kind of highlighted 4 of them. The first 2 I'll go to, and I'll let Aisha deal with the second 2. The first one is, it says accreditation versus sustained quality control. Dr. Yasser is going to talk a little bit more on this when we get to there. But what we want to implement by this is you get accredited, right? And you get that piece of paper. Now what? Now what happens? Okay. What we find is a lot of departments struggle for that piece of paper. They don't implement what they've learned in accreditation, and they go right back to what they were doing when they got that piece of paper. Now, what good does that do? If you've changed all your systems, you should be able to sustain that, right? So there's no sustained quality control. They don't know the difference between just basically getting the accreditation and then sustaining the quality control that they've learned. That's a problem, okay? The second one is when you go through accreditation, there's got to be implementation of some things that you have not been doing. Right? Because accreditation basically is like going to the doctor and the doctor telling you, hey, you haven't been eating right, okay? You've gained too much weight, your cholesterol is high, I want you to take a statin, I want you to do this. You go home and say, I'll take the statin, but I'm still going to keep drinking beer, right? It doesn't work that way. There's got to be organized implementation. What we find is when we go through accreditation, it gives us 20 things that we have to implement. And some departments say, you know what, we only want to implement these 2 because we're only comfortable with those. And they leave the 8. Do you think those departments are going to be successful in quality implementation? Absolutely not. Aisha, back over to you.
Thank you, Joe. I am going to touch on some of these questions so how does utilizing Six Sigma certification impact accreditation for healthcare facilities? That is so important. Six Sigma, I'm a Six Sigma certified. Waste walk is, you must do waste walk in every modality. That would help you efficiently practice in each modality. One of the things that I've done, there was a complaint about one of the techs taking a long time to perform their exam. So what I did was I taken a waste walk sheet and looked at it and followed that tech to the process to see where, and we could have avoided certain things to make this workflow efficient and make her faster. Because sometimes we tend to do a lot of things by the books, and that's fine. I can do that. But you also want to look at it and see what are the things you can eliminate that would make it more efficient. That means you can add on more patient to your schedule, or you can get the tech to do something else other than just continue to take a longer time for ultrasound or a mammogram. So it's really important. Six Sigma certification definitely impact your healthcare facility. I personally have all my staff, at least my manager levels, have Six Sigma green belt. It's so important to have that, so they know, they understand what are the things that they can eliminate to run the practice more efficiently. Does the scope of accreditation include for legacy medical devices? Absolutely. You have to have a proper supply chain process in place to choose your medical devices. Now, ACR doesn't guide you how to do it, but we as a IFC consultant, we do put together a great program for you onto how to have a proper supply chain management that can help you, because ACR will look at it in your accreditation. What is your equipment? What's the quality of your equipment? Because you know what, the PM will give it out. If your equipment PM is not, it comes back, not good, that are failed, it will show you in that. So they will know, well, they applied for the accreditation, but they don't really have a quality equipment. So we help you go through how to choose the equipment. We got lucky with IDH because they had one of the best equipments when we walked in there. We were like, how do you all have Siemens? That's wonderful. We don't have to worry about that. So they already have great equipments when we walked in there. But we're working with other facilities where they need help, and we're working with them. That's where we're starting. We're starting with the quality. We're starting with equipment. We're going into the accreditation piece. So I hope I answered your question. And then I'm going to go into an organized implementation. What does that look like? It's so important to have a right team member in place to run this for you. You cannot just include multiple team member that doesn't have a process in place or doesn't understand what accreditation to implement this. You got to have a proper leader, and the proper leader has to disseminate information to how to get this organized to implement. There's a assistant, there's a certain amount of assistant that you will get, and then you have to disseminate that information to your team and to your leaders, to the doctors, and to the front desk team members. Everyone has to be engaged. Trust me, guys, my doctors weren't engaged when I started this. They said, why? Why do we have to do this? What does that have to do with me? I'm doing a good job on my report. Why do I have to do this? But you know what? That the same doctor is the one that will call me and say, this report is not quality, it doesn't have the right quality. Well, we were there and we got here now. So it changes from where you are to where you need to be. So it's so important to have a very organized team that can implement every guidance and every step of the way. Excellent. Lack of frontline staff engagement. You would say, like I said, the doctors don't want to do this either because it's more work. It is more work. I'm not going to lie to you. It's not easy. And then for staff members, for the technologist or the modality person, it's more work. They have to follow a QA process. They have to make sure the protocols are built and they're following the protocol. They have to do a peer review. They have to check their report, before they submit. So you have to have their engagement. You have to get them excited about doing this. If they're not engaged, it would be difficult. So make sure where you set your level and your expectation up front and say, this is what we need to do because this is what we need, and then go from there. And lack of patient safety integration. You have to have patient in the process as well. What you're doing, state to, share with them what you're about to do, and all the safety. A lot of places me and Joe walks in, there's no zoning in MRI. It's so scary for me. So like everybody can walk through every zone. So you got, from what Joint Commission as well as ACR say, you have to have a proper zone in place for MRI. So that's a huge patient safety when you don't have that, when you don't have staff training, when you don't have patient training on what your zone is, which zone the patient's allowed to do, which zone your staff's allowed to do. There is a whole piece of education that goes with that to integrate that patient safety into MR. So I hope everyone can follow this, and we really are hoping to get this integration and the safety and equality piece into accreditation, and that's what's make your site really high level, high quality, in a prestigious way of practicing medicine. Joe?
Excellent. Thank you, Aisha. So closing up with our part, there's some general standards that the ACR, and I know we're using the ACR, the American College of Radiology, as an example, but it's also every other accreditation body. They all have the same requirements. The general standards that we came in and we found, again, we got lucky with IDH because they had, I would say, a good 80% of these general standards already going. We just had to fill in some gaps. So there are some hospitals we work with that don't have these standards. And you guys are going to have to really consider this before you say, I want to become accredited, because if you don't have these standards already and you're not willing to put forth the work to get them, the accreditation is not going to work. Number one, they're going to want to know what your qualification of your staffs are. You're going to tell them, and Dr. Ahmed, forgive me, I'm going to use you as an example. You're going to say, we have Dr. Ahmed Wafaie and he's the medical director. They're going to go, okay, show us his qualifications. And you're going to go, but he's a radiologist. They said, okay, where did he graduate from? What are his qualifications? What is his license? You're going to go, we don't have that. They're going to go get it and come back when you do. You see, because you cannot have doctors practicing, technologists, physicists practicing that are not qualified. And you and I both know that if it wasn't written, it didn't happen. Right? So make sure that all your staff qualifications, your certificates of training, your medical school attendees, your CPEs, whatever it is that your country recommends or requires for staff qualification is in a file. We can tell you we did this to every single practicing doctor at IDH, right? Because that is what's necessary. Patient safety, we already run into that. Image quality, right? They're going to look at your images. Remember, you're downloading your patient's images onto a foreign website for them to look at those images and tell if those images are diagnostic or not. So no more hiding, underdeveloped pictures. No more hiding pictures that are out of focus. No more hiding pictures that have the calipers in the wrong place. It can't happen, right? And they're not going to ask for one. They're going to handpick all the way across the board. So we're going to have to make sure that if you don't have image quality assurance now, you need to have it, okay? Documentation. Documentation. This is always a problem. Documentation is always a problem. Why is that? Because we as medical people are too busy to write things down. We're moving a mile a minute all the time, right? Dr. Yasser probably doesn't have time to do things because he's got 15 different patients every day. He's got patients coming emergencies. He's got this going on, that going on. But the ACR and other accrediting bodies will ask you for every piece of documentation that you should have on from the time that patient picks up the phone to make that appointment to the time you write out that report. What's the documentation look like? When your equipment gets periodical maintenance. What does the documentation look like that the physicist leaves with you, right? If they come and fix your equipment, what does the documentation look like? If your machine goes down for a day, right? What does your documentation look like? And those of you now, I can't see your faces, but I can hear some increased heart rates right about now, because some of you don't have proper documentation, or you're writing documentation on handwritten pieces of paper and filing it, and you don't know where it is, right? The same people that are writing those documentations on piece of paper are the same people that use iPhones. If you can use an iPhone, you can use digital documentation, and they will ask you, okay? And policies and SOPs, Aisha, you want to comment on that real quick before we finish?
Sure.
off?
One other thing I want to add to the documentation, when Joe say, yes, documenting what's going on with the patient or what your findings are important. What ACR and accreditation helps you is to standardize your reports. One, they tell you what to put on the report. One thing I found it with IDH when we were working with IDH is, you know, it's a very general formatted report when we first started. It's like everything is normal. We saw the carotid numbers. This is all normal study, right? Where ACR says, well, I want to know what's the peak systolic and end diastolic for certain vessels. I don't want you to just tell me it's a normal. So some doctors likes to see that. So we help them structure the report where what's the important information that needs to go on the documentation and their report needs to be put on. So they were so thankful. One of our ultrasound doctor, she was like, wow, that's so important. How did I miss that? Exactly. We will help you set that up on there and on what information to put on there, because ACR, it does guide you. What are the informations important to deliver to the patient as well as the doctors who's ordering it. And policies and SOPs, you know, you can't practice radiology without proper policy in place. When it comes to policy, to have like, for example, it's important to have a chaperone for ultrasound. If you're doing a pelvic ultrasound, what, you know, is there someone in the room? Did you offer a chaperone for the patient? I know everyone's probably thinking, wow, we don't do that. Why do we need to do that? It's so important. You respect that patient privacy. What type of chaperone policy do you have? If the patient says, you know what, I am uncomfortable with you as a doctor, what do you do in that case? You think about it, you answer yourself, but we don't have a proper procedure in place in medicine for that. If a gentleman is coming for a testicular ultrasound, you know, do we have a proper care for him? Do we have a staff member in the room to help and make sure there is a proper privacy policy in place for that? And also, when you are doing CT with the contrast, oral contrast versus IV contrast, if you have an extravasation, what is your policy around that? And what type of reporting are you doing around that? Because it's important that you do a follow-up with the patient. You know, if you have an extravasation and the patient's arm swells up, and do you follow up with that patient, see how they're doing after a day? What do? We have to have a policy around that. MRI, how do you know you don't give a contrast to a pregnant woman, right? Do you have a policy around that? Do you have a policy around what patient with a device, you know, our pacemaker that can go in the MRI or not? What if your patient comes in with a pacemaker or some kind of a metal device, what is your policy around that? How do you go through that? So it's so important. There are lots of policy in radiology, and you have to make sure. The way I do it is every meeting that I have with the staff, I introduce a policy. Even if the policy has been talked about last year, that's okay. Introducing it again, reminding them again that this exists, you must follow, is the only way they will remember. They will say, wow, that's our policy. I'm not supposed to do that. Let me make sure I get somebody to help me with that. So policies are so important in radiology. And if you have samples, you can use those. You also want to make sure you have it continue to update the policy, because it changes every year. You have to revise them. Depends on the contrast versus the needles that you are using. Joe?
Thank you, Aisha. So I don't even have anything to add to that, but in closing, what I would like to say is, even though that no accreditation body is going to tell you that you have to have a policy manual or a scope of practice manual, I would advise everyone that does not have a radiology manual to now start putting one together. And you can send us emails, we'll tell you what should be in the manual, but it'll make it so much easier for you to apply for accreditation, because if you look at the key to this manual here, the first tab has a scope of practice, which you should have your mission statement, and your department services by modality. So if you're, for instance, if you're IDH, their radiation manual now has CT, MRI, ultrasound, PET, and it has listed those tabs. And under those tabs, it has the policies for CT, the policies for ultrasound, the protocols for CT, the protocols for ultrasound. So as Aisha said, if somebody else comes, unless God forbid Dr. Ahmed is sick one day and somebody else has to read for him, they could just take that manual, open it up, and they know exactly what to do. There's no question. I used to always say, fantasize that if something happened, your whole staff disappeared and it had to be replaced by another staff, that policy manual should tell that other staff coming in without training what to do, how to do it, and when to get it done. So a policy manual is very, very important. The last thing I want to say that is, when it deals with accreditation body, Aisha and I have talked about the American College of Radiology, which of course we work with, but there are many accreditation bodies. IDH chose ACR because it fit them perfectly. You don't have to choose ACR, and we can give you a list of them. There's Accreditation Canada, which is a great radiology accreditation international. There are accreditation bodies for people who just practice certain modalities. For instance, high-risk obstetrics just practice ultrasound. So then they use the American Institute of Ultrasound and Medicine because it specifically targets obstetrical ultrasound. The IAC, which is the Intersocietal Accreditation Commission, they do a lot of the vascular work, a lot of MRI work. So the Royal Australian Medical Imaging Accreditation Program with Australia, and then you have the UK accreditation system. And there's probably a bunch of them that I don't even put on here. Just to let you know that international accreditation, guys, it's a thing. It's a thing. It is not to be just thrown in the background someplace like we did 5-10 years ago. Aisha can tell you, when we worked at the hospitals together and they said, hey, you guys need to be accredited, I was one of the first people that said, why? Why do I need to be accredited? I'm already doing what I'm supposed to be doing. But you know what? I can look back at it now and say, thank God I did that, because it raised my quality standard from like 50 to 100. Okay. Mm-hmm. So I want to close this session off. Thank you very much for your attention. Jill, and yes,
sorry, I just want to answer a few questions before we jump into the next segment.
Okay, no worries.
Is the clinical data registry required for accreditation process? No, you do not have to have the clinical registry, clinical data registry first to have the accreditation process. And do you also provide accreditation for independent nuclear medicine imaging and therapy center? If you have a nuclear medicine registry, if you have a nuclear medicine department, we can submit accreditation just for that modality. Yes. All right.
Perfect. Thank you. Thank you guys for the questions. Keep them coming. Really good questions. So with this last part of the webinar, what I want to do is I want to direct some questions at the experts that have gone through this procedure. They say there's no better person to tell you something than somebody that has already gone through it. And Dr. Ahmed, Dr. Wafaie, he's been a friend of ours, not just a colleague, not just a client, but a friend of ours for the last 2 years. We actually try to make excuses to go to Egypt to visit his clinic, just to see him and his staff. But I want to ask you, since you've just been through the accreditation process, Doctor, what were some of the challenges that you could give our audience some scope on?
Thanks, Joe, for inviting us to this nice webinar. As Dr. Hend said, we have successfully achieved the ACR accreditation in 2 modalities, nuclear medicine and ultrasound, in last August. It was a great achievement after a great effort. You helped us through over 2 years, I think. The first challenge we faced is the cost effectiveness of the accreditation process. As you've mentioned, it's a lengthy and a costly process, and everyone in your team must know that the benefits you're going to gain will overcome this cost. So this is the first thing that we have to convince your staff and your management of. The second challenge is convincing your staff or Borg Scan staff on the benefits of accreditation, which are great, and we are going to speak about this later, of course. The third important challenge is getting the team support. You must have a teamwork. Teamwork is the core of successful accreditation, and everyone should work together as one team. If you have this team support, you of course will get through the different problems and the different hurdles to accredit your facility. And the last challenge that is very important is sticking to foreign or international standards, which are a bit different from the standards, the local standards you used to perform many years behind. So this change from local standards to encourage your team to stick to foreign standards was a very great challenge. And thank God we have succeeded in this challenge. And as I mentioned before, and we successfully achieved the accreditation in two facilities to become the first body to be accredited through ultrasound and nuclear medicine by ACR in Africa, in Egypt, in Africa, and one of the few bodies in the Middle East.
Thank you, Dr. Ahmed. No, Dr. Ahmed he's being very, very modest, and I'll pick this up with Dr. Yasser later, but nuclear medicine, which they have had their accreditation, they just received their accreditation in nuclear medicine, is world renowned to be one of the hardest accreditation in any modality to get, simply because nuclear medicine is such a complicated modality. It is not like ultrasound or CAT scan. There's too many factors going on at the same time. There's, decay. There's how do they get rid of the radionuclides? There's how do they dose their patient? There's if you dose a patient, where do you have that patient wait? You can't have them wait next to a regular patient, right? So, we were actually applauded them because they got the nuclear medicine accreditation first, the first one in Egypt that they had. So one of the other questions I had for you, Dr. Ahmed, since I have you here, is we talked about the challenges, but you had to have seen some benefits for accreditation for you to even go through that. It's a difficult process. Why did you even go through it? What did you see as the benefits?
Yeah, of course, we have been seeking the accreditation process to gain the benefits from ACR accreditation. The first of all is the improved quality and standardization of imaging practice, as Aisha said before. The accreditation process is all about standardization, quality, and safety. So if we are performing these three integrated actions, of course we will come out with a result that your exams and your reports will be to a high level that's above other competitors. This is a very important benefit and achievement of accreditation. The second thing is the patient is to gain the patient and referring physician satisfaction. This is very important. When you are accredited, they are sure that you are providing a high quality work with a high degree of safety to the patient. So this is very important, the satisfaction either from the patients or the referring physicians. The third benefit, which is very important, is improving the staff performance. As I said before, we have stuck to foreign standards, which was great. And we will maintain that as a sustainability, as you have said before. And this, of course, will lead us to improve the staff performance with this sustainability effort, staking and achieving the foreign standards. The last thing, of course, when you achieve all of these benefits, then, of course, you will get to improve your organization success. So the final accreditation purpose is that your organization will be success namely in my place, the IDH, Integrated Diagnostics Holding, and Borg Scan, hopefully. Yeah.
For sure, Dr. Ahmed. Thank you so much for that. And the thing about it is the patient satisfaction is a huge one, because I can tell you, and Dr. Ahmed did not pay me to do this. I'm not doing this as a commercial. There's not been one single time when I've been through that office has not been packed, like no standing room. So obviously they're doing something right, because these patients just keep coming back and back in droves. So thank you very much for that. So my next question is to Dr. Yasser, and Dr. Yasser is the nuclear medicine guru of Borg scan of IDH. And Dr. Yasser, you've been through this accreditation process as the most difficult modality to accredit. We know this. I mean, those of you who don't believe me, look it up on the internet. Nuclear medicine is not an easy modality. So what advice would you have to give to not just nuclear medicine modality, but other modalities that are now thinking about going through accreditation or actually have stepped into accreditation?
First of all, thank you very much, Joe. Thank you, Aisha. You put us on the way, on the road. Thank you very much, Dr. Hend Sherbini, the CEO of the firm that I'm proud to belong to it. And I'm proud to belong to Dr. Wafaie's team. Very important. First of all, go to the link of the accreditation ACR and take the sheets and read it and study it. All of us have some humble experience in our specialty. You will find many new updates, and many things will help you in management and direction medically through the link and website, first of all. And we are in the medical field, we got used to study a lot and study hard. So read well. Yeah, yes. Read well the sheet. You will use a lot of benefits of the ideas. Then meet the expertise. Meet the people like you. Put us on the way to coordination. ACR is a very important thing for nuclear medicine, because it is the most difficult accreditation all over the world, as you know, Joe. Especially in nuclear medicine, which has a lot of aspects of care. Patient first one, but also occupation is second. Our equipments, the maintenance that you have taught us how to do it according to the American College of Radiology will save money actually to the firm that I work with, and it will save money, if money is very important nowadays, for the patient himself, because you can protect the patient to go through many modalities and he has no goal. And the referring physician also has no goal eventually after the report. So my point of view, my humble experience, ACR put us in the way in a country like Egypt with huge population, as you know. We are the first in Africa, as you told us, among a few centers in the Middle East, okay? So this is true, a proud and bright. Having the qualified team, that's what I started with. That's why I have the loyalty and proud to work with IDH and with you. You are among our team, actually, I consider that. Because we have the maintenance. We have 2025, inshallah, the end date of this validity, in which we have to keep every tiny paper, which is the maintenance. I call it maintenance and consistency of the accreditation. It's very important. It will care about the patient. It will care about the cost effectiveness of everybody. It will care about the occupational, because you have to choose your teamwork and give them the passion of this high brand accreditation. And let me tell you, Joe, do you know the brand gamma camera companies? I will not mention names, okay? But they will be proud to cooperate with you again and again and again with many facilities if you have such accreditation. Yes. Because such accreditation even will accredit the company and the equipment itself.
True.
Okay. Okay. Right. And in some places like Middle East and Africa, you will find who is supervising the quality of gamma camera and radioisotopes. It will be the International Atomic Agency.
Yes.
Okay. Regarding radiopharmaceuticals and radioisotopes, and as you know, we are going through low dosage therapies that can be given outpatient like in America.
Mm.
And the nuclear cardiology CT hybrid image with gamma, which can give a better radiation dose, should be accredited for outpatient nuclear cardiology as well as oncology. We are caring about oncology patients and cardiology patients. My point of view, they are the most important patients all over the body, all over the world, because they are following you up. You have to have their trust, because the patient will ask his physician, I want to go to those people who has the accredited, maybe he doesn't know that we have ACR, but he see himself. That how we reassure the patient. How do we are doing consents? How do we are supervising and making incident reports? By the way, incident reports is a many important issue that you have taught us through ACR. Because in the Middle East and regional and Africa, incident reports were not there. It is not there because everybody may think that I'm making a report like an investigation, the employee. But when you have the teamwork, told them what is the value of incident report? It is to remodulate and correct any tiny mistakes. As you said, Joe, nobody have no mistakes. Nobody is perfect. And we can find tiny mistakes that maybe affect the details. When you are going through these guidelines, and accreditation is a brand in USA, Europe, they are using them. You will have the trust of the occupational people, patients, and referring physician. Diagnostic holdings is many things, reaching about 100% of the management of the patient. If we are talking about a huge firm like IDH, containing the pathology, the radiology, all modalities, nothing is shorted or defected, and laboratory. So what else you need except to open and then unduly detect? When you are detecting the patient in such a complementary guidelines of all modalities, everybody will be satisfied.
Thank you, Dr. Yasser. And Dr. Yasser, actually, he actually did mention, Dr. Ahmed actually mentioned that you guys kind of crossed it. And there's a way that you did things before, and then there's a way that you're doing things now. And not everything needed to change. We know that not everything needed to change, but at the same time, you guys embraced the change. And that's a very, very, very important thing. Dr. Yasser, I'm just going to ask you one more question. How do you plan to sustain what it is that you've done? I mean, you guys have gone through a lot. You've changed a lot in your nuclear medicine department based on what you've gone through. So to close, how do you plan to sustain this change?
Okay. Look, Joe, I'm smiling because I love the issue. Wallah, you made me love the issue because it is a wonderful experience, actually. Maintaining is maintaining because you make the teamwork. Dr. Wafaie make the teamwork, first of all. Now, everybody in Borg scan knows his job description and knows his job description according to our ACR. So, documentation, we are keeping on every day. Maintenance and quality control of our equipments, and a lot of equipments in gamma camera, but we are keeping on daily for the SPECT gamma camera, for the hot lab, for the radiopharmaceuticals, for reading and monitoring radiation exposure to occupational and even for patients, and recording everything. Like we're studying the link and sheets of ACR, you are also studying our documents in ACR accreditation. So we are coping whatever we are finding on the link from now and then, even updates, we are keeping on updates and documentation and incident reports. Any tiny part, we are going to keep it within perfect quality, hopefully, inshallah.
Perfect, perfect. Perfect. Thank you so much. And you guys cannot tell that these two doctors are very enthusiastic about what it is they do. They don't seem enthusiastic at all, do they? The thing is, I think that if you're not enthusiastic about doing this, please don't do it. It's kind of like going into a relationship. If you're not enthusiastic about it, don't do it, because it will not serve you well. There's too many components, there's too many ins and outs, there's too much work that has to be done. So to close off, let me just say this. It's been wonderful speaking to all of you. I love the questions that come by. I thank you, Dr. Ahmed. Thank you, Dr. Yasser.
Thank you. Thank you very much.
Thank you, IDH, for allowing us to take part in this journey with you, for allowing us to guide you in this accreditation process. It's been a pleasure. And like I said,
thank you, IFC. I just want to thank you. Sorry to interrupt.
Dr. Hend, we want to thank you and your leadership, because we couldn't have done it if you set the example of quality and where it needs to be up high. And I think Dr. Ahmed and the team took it. So we really thank you for your support and supporting your team throughout this process and being there for them as well.
Thank you, everyone. I want to thank IDH team and IFC, of course, for the help. And I hope you'll always be, at delivering a very high quality service to our patients, because they deserve it.
Absolutely. Absolutely. Thank you, guys.
Thank you so much, Dr. Hend. And that's not the end yet, because we still have questions and answers to discuss. Dr. Ahmed, you wanted to say something?
Yeah, I want finally to thank Dr. Hend, the top management, which has supplied us with all what we need and supported us to go through the accreditation, the staff accreditation, really, from the start. And she was the pushing machine behind, actually. And of course, I want to thank the IFC team, namely all of you. But Joe and Aisha have worked closely with us, and they did very great job in from the start over 2 years till now, to ensure that we are on the correct path, and we are going to succeed through our journey with ACR accreditation. Thank you, IFC. And thank you, of course, again, Dr. Hend, the top management and the machine behind our energy through the course.
Yeah, and that's a great example of the role of the leader and leader's support in any quality journey. It's just not possible to reach any results without dedicated leader who is passionate about quality, who believes that it is worth it. This is a great example. And generally, it was interesting to discuss this case, and this is not the end yet. I wanted to warn our audience once again, please do not leave. Let's discuss questions and answers. Some of them were already covered today by our wonderful speakers, but we still have more. So one of the questions is actually converting all of this discussion today into action. Say a facility decided to improve radiology safety and effectiveness. What should be the first step? And here, basically, I want a piece of advice from IFC team and a piece of advice from Aalborg Scan team. So what should be the first step? How to choose modality to begin with? How to choose accrediting body, and any advice, any tips here? So who would like to start? Jo, would you like to start? Yeah, thanks.
Sure. I can do that, Julia, thank you. So we would come in, we would really do a quick walkthrough and look at and see where you guys are. So what's important when you're choosing accreditation? We can choose accreditation body, that's probably the last one, but to look to see where you are in each modality. And to be honest with you, I'll probably choose from the easiest, the things that you're already doing correctly, that I don't have to come in and change a whole lot of things. So if you are doing really well, you have a policy set, standard set in CT, let's apply for CT, because it will be an easy process, and we can get the accreditation faster. And then really look at all modality together and see where are the things we need. High level, there are high level quality policies and protocols changes that needs to happen in order to set the standard to submit. So that's where I would begin. We would have to look at where you guys are currently, the current state, and the state that needs to be for accreditation and what the set the expectation. An accreditation body could be, depends on where you are located, I would say. There are international accreditation. There was another one, RadSite is another one that they offer in US, ACR, IAC. There's European accreditation. It really depends on what makes it easy for where you are and where you're located, in my opinion. Joe?
Yes, just to add to that, you really have to take an overall look at your systems. Okay, what are your system processes now? And if you don't, and if you're looking at me going, what system processes, then we know where you are. Okay, and it's not a bad thing to be at ground zero because you can only go up, right? So what are you practicing now? What does your safety look like? And you may say to me, Joe, how do we even find out where we're supposed to be? Dr. Yasser gave you a very good suggestion. Go on websites, pick an accreditation body, whether it's ACR, IAC, they have all the standards listed on their website. Pull down the standards, go to your department and say, hey, are we doing this? Are we doing this? Are we doing this? Yes or no? Self-assessment. Once you do the self-assessment, you'll get a pretty good idea of where you need to go from there out, okay? Thank you.
Thanks a lot, Joseph. So any more advice from Dr. Yasser, maybe Dr. Ahmed, as the other side of the journey, as the team who actually was accredited?
I just want to say something here.
Yes, please.
I know that accreditation is a lot of work and a lot of money that we put in and a lot of resources. However, at the end of the day, it pays a lot. You know, not just that we are delivering the best quality service to our patients, but it also gives returns in terms of financial returns. Mm-hmm. And I've seen this with the lab, because we've been accredited now for more than a decade, and I'm sure we're going to see it with the radiology as well. So I don't want leaders and managers to be afraid of spending resources and money on accreditation, because it always pays off. And of course, you're also doing what's best for your patients and for your staff, but it also pays off in terms of financial returns. Thank you very much.
Great point, Dr. Hend. Thanks a lot for mentioning this. So actually, next question is a very specific one. So maybe I think it is addressed to IFC experts, to Joseph and Aisha. If a facility has already Joint Commission accreditation, is there any point going for a specific radiology accreditation? That's part number one of the question. And second part of the question is basically, should it be accreditation for just a radiology chain, just a diagnostic facility, or if it's just a department in the hospital? It's a related question, right? Should it be accredited by radiology specific type? So these angles of the same issue. Thanks.
Absolutely. I really believe in a specific accreditation, because you wouldn't go to, right now, the way medicine is going, it's specialty, right? So you won't go to, you won't get your knee done with your dentist, correct? You don't want him to fix your knee. You don't want dentist to fix your knee. So the way I see it is, yes, Joint Commission is really good accreditation, and they look at the overall quality, but they don't come in deep into your modality. So that's what's important. They don't look at your protocols and very closely. They don't look at certain way of your practice in radiology closely. So I think it's important, and it's prestigious, like Dr. Hend said. It is going to make a difference in your financial when you have your radiology accreditation as well. Now, the place I work for, we have a Joint Commission accreditation, and we have every modality accredited in radiology as well. When you have that, you also can apply for a Diagnostic Center of Excellence, which is an amazing accreditation to have. And you basically say, we have nothing but excellent care for you. Why wouldn't you want to be that person, right? So it's important to have a radiology specific accreditation, in my opinion, because that sets a different and higher standard for everyone that practicing radiology.
Yeah. And in addition to that, Aisha, to piggyback on that, and I've been asked that question before, why can't we just put the entire center instead of like, if you look at IDH, why can't we just go in and say IDH is good quality instead of saying CT and IDH is good quality, nuclear medicine and IDH? Well, my question is, if you're going to a practice, let's say you're going to go get surgery and there's 10 surgeons in there and the whole practice is accredited, would you pick that one versus the one that you know that every surgeon had gone through extensive training in the procedure that you wanted? You would probably pick the latter, right? It's the same thing. Now, I should also, I think Dr. Hend mentioned the reimbursement and how the money was going to be worth it. We're a world that's pushing towards United Healthcare. We're pushing towards it. Africa, where I live, is pushing towards United Healthcare. The United States has third-party payers where insurance companies reimburse the hospitals. Insurance companies in the United States look at if you are accredited as a radiology department, deciding on how much to reimburse you. The company that is accredited will get reimbursed at a higher level than the company that is not accredited. So why would you not want to do this? And with us pushing towards United Healthcare, I guarantee that this is going to be the same thing with third-party insurance. So get ahead of the curve. Thank you.
Yeah, you actually get a certain higher amount of rate with different payer mix. And I'm talking United States, I know every country is different, but each payer will pay higher, depends on where you are and where you're certified, where you're accredited. So for example, in the US for Care First, we get about 200% of reimbursement. That's really high. That's a good rate that we negotiated, but that's because they looked at our quality of work, they looked at where we are, and they say, yes, we can do that for you. So that's really important.
So just one more thing.
Yes,
if you're looking at the quality of work, right? Because third-party payers are going to want to look at your quality, right? They're going to ask you, what is your quality, X, Y, and Z? Guess what accreditation does for them? It saves them the trouble because they already know that the ACR is quality. As soon as they see that ACR, they don't have to look at you anymore. They already know your quality.
Thanks, Joseph. Next question is actually a tricky one. You, Joseph, mentioned self-assessment, and Dr. Yasser mentioned that we can always look at ourselves downloading the standards from the multiple websites of accrediting bodies. Is there any obstacle? And I can tell you, I expect the answer no to this question. Is there anything that can be a serious obstacle so that the facility can say, oh, we'll never get this accreditation? Yeah, so because I don't have equipment which would be like high level or sophisticated, or because my facility is not compliant or something like that. So are there any serious obstacles to accreditation, or anything can be done by process compensating, basically?
I would say that the only obstacle is if your patient mortality is off the scales, then you probably shouldn't go for accreditation, okay? But apart from that, it doesn't matter how old your equipment is. It doesn't matter if you have 1 doctor versus 10 doctors. Accreditation is for everyone, and that's why accreditation guides you through the process. They don't just come to you and say, be accredited. They say, where are you now, okay? And based on where you are now, here's the work you have to do to get to where you need to be. IDH was at a certain level. I'm going to go to other hospitals that IDH is going to be here, and these hospitals are going to be here. It doesn't mean they can't become accredited. It just means they're going to have to do a little bit more work to get up to where. So don't make that an excuse. I've seen ultrasound departments accredited with ultrasound machines that are 7, 8 years old, okay? It's not a matter of the equipment. It's a matter of the want, the ambition, and the drive for quality. Aisha?
Thanks a lot, Joseph. That's music to my ears.
And accreditation bodies help you get there. I don't think they want to be the barrier. They help you. They want you to have the quality standard. There are a lot, like Dr. Yasser and Dr. Ahmed can say, we went through where we went back and say, can we get an extension? Can you help us get this loaded? They've always been open to it. They want you to have this. So there are no barriers in my opinion.
Thanks, Aisha. That's a great point, actually, and it is relevant to my next question. Okay, once the facility decided to get accredited, benchmarked themselves against the standards, did the self-assessment. So what's next? How do they actually improve, and maybe what sources to look for, where to seek advice, etc. Again, we need some practical tips here. And would be great also to hear from Dr. Yasser and Dr. Ahmed what can be a good solution for such a facility.
Let's hear from them first.
Okay, sure.
Want me to take this answer, Joe? Actually, what I have learned by journey, Dr. Iman Farid was a coordinator between us and you, which is again forming the first teamwork to put us on the way. Explain everything. Like an example, our dose calibrator, remember Joe, in the hot lab, that we have something which is, and then Dr. Hend Sherbini pushed and funds the thing to modulate. So forming the team, have the funds and go.
Yeah, I will summarize, Joe. First of all, you must believe in yourself. You must believe that you are going to succeed in the accreditation process. Self-belief is very important. The second thing is to form a teamwork. This is very, very important. Teamwork in every aspect of the accreditation, in every modality. This coordinated teamwork is the key of success. If you have the self-belief and the strong coordinated team, you will succeed. Whatever, as you have said, whatever the machines you have, is it old, is it new, the numbers of doctors, the numbers of consultants, but self-belief, I think, and teamwork are the two key cornerstones in the success of the accreditation process with whatever the body is, whatever the accreditation body is.
Thanks a lot, Dr. Ahmed, Dr. Yasser. These are great points. So let me repeat, because it's just so important. Number one, leadership support. Number two, teamwork and a good project manager. This is definitely key to success, and please do not underestimate the importance of it. And I think Aisha and Joseph wanted to add something on this point.
Aisha?
No, I think Dr. Ahmed and Dr. Yasser touched it very well. So honestly, they brought up the key points for me. So I think thank you guys really for your participation, and continue to help us and help your team. It's so important when you go in there, like Joe said, when you go in there, the coordination care that they provide in IDH, it's amazing to me. I wanting to go back, and I would get services done nowhere else in Egypt except in IDH. So they really set the standard high. People are kind, and the doctors are just one-on-one. They listen, they take care of them. So it's so important to develop a practice like that, because you don't see that in a lot of places anymore. They just want to get things done and get you out. And really, we can't do that. It's medicine, and people are nervous. So when they come into the site, it's the personal one-on-one care they get that we have to be really cognitious and really help them get there. And really, IDH team done a fantastic job with that.
Thanks a lot, Aisha. And anything on this point, Joseph, before we conclude, because basically I think we're already running out of time.
No, I'm good. I just wanted to thank everyone. IDH, you guys need to be commended. You guys are now an example. And the problem with being good is people start following you. Okay, that's the problem. So it's a good problem to have. And hopefully you guys are the first of many in Egypt, many in Cairo, many on that end of Africa that will take up this ball and run, because we need good quality patient care. Good quality patient care. I often say to my colleagues when they're talking about, competing for patients, I'm like, when are we going to run out of patients? We're never going to run out of patients. Let's stop competing for patients and compete for patient care. That's what we need to start doing. Okay. So thank you, IDH, and thank you all.
Thank you.
Thank you so much, Joseph. Thanks a lot to the teams today. Yeah. Somebody else wanted to say something? Yes.
No, I just wanted to thank you. Thank you very much.
Thank you, Dr.
Okay.
Han.
Thank you, Dr. Hend.
Wonderful. So thanks a lot to our wonderful speakers today, to Dr. Hend, to Dr. Ahmed, Dr. Yasser, to Aisha and Joseph. We thank our audience for staying a little bit longer to